Dr. Ralph Haller's with us, and he's never been on, so you deserved the Ask the Surgeon opening for you. So welcome.
Oh, thank you.
We're going to be talking about labral tears in the shoulder. Did I get that right?
You did. That's good.
You know how I know how to pronounce that? Because I'm a sports fan. That happens a lot in sports, doesn't it?
It does.
Don't they tear labrals? So what is that?
Well, Moria, the shoulder has a very shallow socket, and I think it's made that way so it allows a tremendous amount of range of motion. And the labrum is a ring of cartilage around the socket that deepens the socket and makes the humeral head fit in there better. And it's also an attachment point for ligaments.
Just tissue and different connections in the shoulder?
Yeah, it's a sort of triangular-shaped ring of cartilage that just deepens that socket and has a lot of tissues that connect there, too.
So the shoulder, basically, when we talk about it, it's got a large ball that sits in a small socket.
It does.
The labrum allows that ball to have a little more surface contact with the socket then.
Yeah, and when everything works well, it even creates a little bit of a suction fit.
Okay.
The joint fluid there.
Well, and so when we talk about labral tears, I mean, these as a normal person every day, we don't hear about these a lot. And are we just starting to discover these more, better diagnostic test? How come we're seeing more of them?
I think that's the main reason, Shannon. There's really no way to diagnose it with an X-ray until the MRI, especially the MR arthrogram, where you inject some dye and then do an MRI, came about. You couldn't really see the labrum very well, and so I think that's one of the main reasons for diagnosing it.
Well, just for those people listening out there, the labrum, like you said, is cartilage, so it's not going to be picked up by X-ray.
Correct.
Okay.
It's totally invisible to regular X-ray.
Right.
So is that MRI then? Is that how you...
The MRI is how you diagnose it, yes.
Right. And well, a lot of times the MRI with, they're injecting some type of dye in there, aren't they?
Yeah, and like I was saying, just a plain MRI, even that isn't always diagnostic. And if you have to inject some contrast in there sometimes to really see it.
So just to review, the labrum is the cartilage around the socket, and sometimes it becomes torn and injured. What would a person feel? What would the signs and symptoms be for a person if they had a labral tear?
Well, there's two kinds. There's an acute injury, which you can get either by falling on an outstretched arm or probably more commonly a traction injury. Like, for instance, last week I had a truck driver who was getting out of his cab, and he slipped, and then he was left holding the bar, and he all of a sudden was supporting all of his weight on his shoulder and
hanging,
basically. Yeah. So that's one way to do it. The other way, in sports, it's more common in throwers to have a chronic injury where from the repetitive motion of throwing, you eventually wear out the posterior and superior labrum.
So symptom-wise, these people would just have pain that just kind of comes and goes, never really goes away. What are they complaining about when they come to your office?
Some have just ill-defined aching, often in the posterior part of the shoulder, the back of the shoulder. Sometimes they have clicking, painful popping with certain motions. Unfortunately, for labral tears, there isn't any one thing that you can just say, this is it. You have to talk to them, get the story, you have to do an exam, you have to do the MRI. And even with all that, sometimes it's hard. Sometimes you have to look with the scope in there and actually look at the thing before you can finally tell that that's what the problem is.
So when you talk about the scope, you're talking about the arthroscope?
Yes.
And then you stick that inside the joint and you kind of look around and explore that?
Yeah, it's a surgical procedure. We take an instrument that's as big as a pencil that has a TV camera on it, put it in the shoulder. The shoulder is not quite as big as the knee, but it's still big enough you can move that instrument around inside, look at the labrum, look at the cartilage or the cartilage on the end of the bone, which we call the articular cartilage. You can look at ligaments, all sorts of things.
Just
inside.
Explore that whole joint there.
Yeah. Mm-hmm.
So we know, these kids that are overhead athletes, throwers, volleyball players, anybody that have this chronic shoulder problem that doesn't go away. Now, are they going to have pain with activity during the activity, or is it going to be after the activity? Do you have any sense on that?
They mainly have pain during the activity.
Okay.
During the throwing, they can't throw quite as hard. Their velocity will go down just because they have that pain at the end of the throwing motion.
I mean, do they have clinically? Do they have weakness? I mean, do they feel certain weakness, or can they, on muscle testing, are they strong all throughout planes?
I think they're pretty strong. I think they're mainly inhibited by pain. So,
Okay.
a functional weakness, they just can't throw as hard just because it hurts at the end.
So then you do arthroscopically, you go in and you see what the deal is. Do you fix it arthroscopically?
Yes.
Right then?
Usually right then. It's pretty incredible to what you can do, what people have developed over the years. You can put we put various cannulas in, which are these tubes, plastic tubes that are about 7-8 millimeters in diameter. And you can run various instruments through there and also tie knots, put stitches, tie knots all through these tubes that are about 4 inches long and like 1/4 inch in diameter.
You could. I could.
Well,
I barely can tie my shoe, for God's sake.
Yeah, so
That's amazing.
it takes a lot of practice.
Yeah, I bet.
It is
I
pretty
bet
incredible. They're tying these knots outside and then sucking that knot down through the tube and doing these repairs through
That's
the
right.
scope.
And
Were you pretty good with video games as a kid, or were they around?
They didn't have video games when I was a kid.
You're getting better.
So you're busy tying knots then.
Yeah, exactly.
Well, there you go.
Yeah, so we go to a lot of conferences, and they have various models, shoulder models that you can tie knots, and you practice on cadavers, and then eventually work your way up to real people.
So once you diagnose this labral tear and you repair it, what's the recovery expectation?
Like for a pitcher.
Yeah, let's talk about someone like here, a baseball player.
Well, they can, for the first maybe month, they're pretty sore. They're just working on getting their motion back.
Okay.
Then for the next couple months, they're doing still working on their motion, getting some generalized strengthening. And then maybe by 3 months, they're doing some light throwing. But full pitching, probably 6 months.
Mm-hmm.
So they're done for the season then.
They are done for the season, yeah.
And are you seeing this more in your practice with younger kids these days, or is it just has that changed? Because I mean, these baseball players and kids are just in general active, real active today.
Right, and yeah, we are seeing it a lot in high school athletes. I think in general, people are finding that these days kids are zeroing in on one sport.
I agree.
And they're doing that
Good point.
whole year long.
Right.
And in the past, and it's probably safer to do 3 or 4 sports a year, and then you don't overuse the same muscles and tendons and so forth and get the injuries.
Right. Is there any situation where you just wouldn't repair the labrum? I mean, if it was torn and you just wouldn't repair it?
It's a very common injury as you get older. And like if you scoped people's shoulders that were 40, 50, a lot of them would have labral tears. A lot of them are not symptomatic. I don't know if it's because they're not throwing hard like the young kids do, or just something that just don't hurt, and certainly wouldn't repair one if it didn't hurt. And in older people, they often don't heal very well anyway.
Okay.
So then they would feel it like going and playing catch on like Thanksgiving, and their shoulder would be killing them like for 2 weeks after that.
That's right, yeah.
So what about a perception or predisposition, I guess, to arthritis? If you had a torn labrum and you didn't get it fixed, I mean, is there any problem there?
Probably not. One of the common labral injuries is an anterior labrum tear, what you get with a dislocated shoulder. And it's also called a Bankart lesion. People may have heard of that. If you have a shoulder that keeps dislocating, then that causes arthritis. So that's a little bit of a different thing than
you're talking about hypermobility. Then you're talking about too much motion in the shoulder.
Right. Too much and abnormal motion.
Right. So let's talk about this biceps tendon we talk about. It comes up and attaches. That attaches on the top part of the labrum.
Yeah, the biceps is a strange structure. The muscle sends a tendon that's, again, about as big as a pencil and attaches inside the shoulder, this long, strong tendon to the top of the labrum. And in a lot of throwers, they eventually stress the biceps from the repetitive motion, and they start to pull the labrum with the biceps attached to it off the top of the socket there.
And that's called a slap tear.
That's called a slap tear.
All good stuff. We're out of time, I'm sorry to say. We'll definitely have you back. We have a million questions.
Ralph was just getting warmed up.
That's right.
He was just getting going.
He's really good. That's how Ask the Surgeon works. That's how this segment works.
I haven't put my plug in for Shannon for the importance of physical therapy and all this. So.
I think the whole show puts the plug in for Shannon. We encourage that kind of behavior. We'll have you back. Thanks a lot.
Okay, thank you.
We're live from Aquasox Stadium. This is Health Matters on Fox Sports 1380.